Today I'm going to talk about the remaining part of abdominal pain management. In the previous part, I talked about the red flags, which includes the life-threatening injuries, the life-threatening diseases which needs adequate and prompt and quick reaction, the symptoms associated with life-threatening injuries, and what to do first. Remember, I've been talking in my previous lecture as well. Being an emergency physician, when you receive a patient in emergency department, three most important things that you need to have to consider in a patient with any sort of pain or any sort of disease. That's airway, breathing, and circulation. That implies to abdominal pain as well, which was taught in detail in the previous lecture. Next, in the previous lecture was talked about the position of the organs that are placed and how the pain in that specific region can demonstrate or tell you a rough estimate about the disease. Lastly, it was the detailed history of a pain. Today, continuing the lecture about pain management, there are multiple things that need to be considered in detail. And for now, when you are taking history and going further for evaluation, you have to make sure the patient is vitally or hemodynamically stable, or his airway is secure, his breathing is adequate, the perfusion to the organs is adequate, and circulation, there is no blood loss or external hemorrhage. So moving on. So concerning diagnosis. With examination finding, there are multiple things that you can elicit with the patient presenting with any sort of abdominal pain. For example, a patient present with abdominal distension or bilious emesis. Think of constipation, bowel obstruction, volvulus, or malrotation. These things will be explained in detail further in this lecture. Next, if a patient present with fever, right upper quadrant pain, and jaundice, think of cholangitis. A patient can present with ascites, for example, in a patient with cirrhosis or hepatitis C-related decompensated liver disease, or portal hypertension. But Chiari syndrome can present with ascites. So if a patient presents with ascites and abdominal pain, or there is fever with it, think of spontaneous bacterial peritonitis. Next is blood in stool. There are multiple reasons of blood in stool. Upper GI bleed, variceal bleed, ischemic colitis, inflammatory bowel diseases, intussusception. You can present with blood and stool. So abdominal pain can present with other extra abdominal diseases. It's not important that abdominal pain is solely or always abdominal in origin. There are multiple other diseases, which I'll explain in this couple of slides, that can present with the abdominal pain. Moving on to gastrointestinal manifestations, can present with constipation, diarrhea, and bleeding. These can present with abdominal pain, though it's an abdominal manifestation. Blood or current jelly stool, nausea, vomiting, or anorexia. Nausea, vomiting, and anorexia can present with various kinds of diseases. Can present with acute MI. Can present with other diseases, electrolyte imbalance. Hematuria, indicate bladder irritation, can present with abdominal pain. Dysuria, urgency, frequency, can be associated with abdominal pain. So gynecological, this is very, very important because at 12 weeks of gestation, there is enlargement of uterus that makes difficult for abdominal examination. So abdominal pain can present with contraceptions, sexually transmitted infections, pregnancy and fertility, menses and vaginal discharge. Sometimes there is mid-cyclical pain in females that is common and during or after menses. After regular cycles, especially mid-cyclical pain passing halfway through the routine cycle, they can present with abdominal pain or mid-cyclical pain. That can also present with abdominal pain. Dyspareunia, painful intercourse, can present with abdominal pain. Cardiopulmonary. This needs to be emphasized. At times, there's a patient who has multiple risk factors, especially with diabetic patients. You cannot be sure if a patient presents with abdominal pain, if this is abdominal in origin, or is there any cardiac manifestation underlying. Because what happens in diabetes specifically, there is neuropathy. When there's neuropathy, the pain appreciation is lost, and the patient cannot appreciate the extreme pain of cardiac origin that is appreciated otherwise. So it should be considered an elderly or multiple risk factors who should present with abdominal pain should first go through an EKG. As a simple procedure, simple test, won't take much of your time, but it can give you enough of information and can help you identify the life-threatening causes. So, abdominal pain, pulmonary embolism can present with abdominal pain. Dyspnea can present with abdominal pain. At times, there is pneumonia. Pneumonia at times can present with abdominal pain, or abdominal pain can present with pneumonia. It happens because there is diaphragmatic irritations with the lungs lying over the diaphragm that can present with abdominal pain. Acute MI, as I said before, if a patient presents with multiple risk factors, if the patient has a history of cardiac diseases or cardiopulmonary diseases, or if the patient is diabetic, go for an EKG. Again, it's a simple, won't take much of your time, but can give you enough of information that can help to save patient's life if it's a cardiac in origin. Cough and chest pain. At times, when there is long-standing cough or chronic cough, especially in the patient with COPD, they can present with abdominal pain. Chest pain, because of high bouts of cough, can present with abdominal pain. Systemic causes, diabetic ketoacidosis. First, you need to know what is diabetic ketoacidosis. Diabetic ketoacidosis is especially in the patients with type 1 diabetes. What happens in type 1 diabetes, there is no production of insulin. And with no production of insulin, there is glucose increase in the body, which the body replicates as mode of starvation inside the body, which help digest the lipids inside. With the lipids digestion, there is ketones production, which help deregulate the normal mechanism inside. So what happens is a patient with known case of type 1 diabetes, or it can occur in type 2 diabetes as well. But if a patient can present, a young patient more specifically can present with abdominal pain or disorientation, think of diabetic ketoacidosis. At times, abdominal pain is a common manifestation in the patients with diabetic ketoacidosis or patients with insulin-dependent type 1 diabetes. So this is an emergency. So every time I focus on some diseases, think of first an emergency, because this is an emergency medicine lecture, and you have to identify the life-threatening or limb-threatening conditions that need to be treated as soon as possible. So abdominal pain is associated with uremia and sickle cell disease as well. Can present with glaucoma. Systemic lupus erythematosus is an autoimmune disorder, most commonly in females. So again, moving on to systemic causes, alcoholic ketoacidosis. Again, there is increased ketones inside the body. Increased ketones, increased fatty acids, increased acidosis. This is also a life-threatening condition. You need to treat this as soon as possible. These all should be and would be considered in the patient in chapter of diabetic emergencies, and will be explained later in more detail how to manage. Hyperthyroidism, decreased TSH, increased T3, T4 levels, can present with abdominal pain. Musculitis can present with abdominal pain. Porphyria can present with abdominal pain. So, strep pharyngitis, these infectious causes can present with abdominal pain. Rocky Mountain spotted fever, this is a viral illness, can present with abdominal pain. Infectious mononucleosis, a positive monospot test where cervical lymphadenopathy, pharyngitis, commonly associated with Epstein-Barr virus, can present with abdominal pain. So mainly the viral etiologies are managed symptomatically until unless it's proven to be patient needs admission for other management as well. So abdominal wall, muscle spasm can present with abdominal pain. Any trauma, any injuries, any vigorous exercises, sudden onset of abdominal spasm can present with muscle spasm can present with abdominal pain, especially the cramps, which a patient gets when they have multiple episodes of loose stools or diarrhea going on. Muscle hematomas, a collection of blood and the abdominal wall, can present with abdominal pain. Herpes zoster, a vesicular lesions, can present with abdominal pain. If you examine the abdomen, which is explained further, how to examine what to do, what next to do in examination of abdomen, you will realize that with herpes zoster, there are vesicles, eruptions, or they follow a dermatomal pattern, which can be seen on inspection in abdomen. This can also present with abdominal pain. So next is physical examination. It's a very, very important part of examination. Again, I will review back to our previous lecture in abdominal management part 1, and I will revise or recommend you to go through it again before going through the slides. Why is physical examinations important? Because it can give you a very, very important and life-threatening underlying disease information within minutes. You don't have to go for a CT scan or for further extraordinary lab investigations to get to the diagnosis, because in emergency, diagnosis comes later, protecting the patient comes first. Even if you don't know the diagnosis, don't worry. But if you know the patient is safe, hemodynamically stable, you have enough time to make the diagnosis. Yes, it is important to make the diagnosis, but not on the cost of patient's life. So physical examination. First thing, you would have to realize general appearance of the patient, because this gives you enough information. If the patient looks toxic, if the patient looks ill, pallor or distress, again, moving back to airway, breathing, circulation, A, B, C. Because if you don't treat the airway, breathing, and circulation, you might lose the patient. But how do you recognize if the patient's airway, breathing, and circulations are stable? How? General appearance gives you enough information. So pallor or distress can give you information that the patient is acutely ill. It can present with multiple diseases, for example, acute pancreatitis, sudden abdominal pain, toxic look, give you a blank. This patient needs extra attention. Patient with abdominal aortic aneurysm, patient with mesenteric ischemia can present with these kind of symptoms. They can look like distressed or acutely ill. Peritonitis, mesenteric ischemia, these are diseases that can present with severe manifestation and severe diseases. And if you tend to look at this patient, you'll find this patient is toxic or this patient is not looking well. Gastroenteritis and urinary colic, these can also present with acute distress. How can gastroenteritis present with acute distress? It's multiple episodes of diarrhea and vomiting. Yes, dehydration. Dehydration, significant dehydration can present with toxic look, pallor, distress, or altered mental status. Urinary colic can present. The pain of urinary colic is so significant the pain is unbearable at times. So this patient is acutely ill. So vital signs: hypothermia or fever. Give you a blink. If the patient is presented with hypothermia or fever, think of an infection underlying. But what to think with fever? Yes, sepsis. Think of sepsis, which can eventually lead into septic shock. It is not always important that sepsis can present with fever, but yes, fever is a manifestation of sepsis. So, acute appendicitis and cholecystitis, hypotension and tachycardia. So, again, when you realize the patient is hypertensive, tachycardic, and having a fever or not having a fever, there is the history that you can take can give you information. For example, if a patient with dehydration can present to you with hypertension and tachycardia, that's a reflex tachycardia. This can give you a blink. The patient is dehydrated, can go into septic shock, needs treatment adequately. So what to do? Fluids, 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 and fluids. This is the main treatment for sepsis. It's explained in the other lectures in sqadia.com. So, moving on to abdominal examination. Abdominal examination is very, very reliable and it gives you a lot of information if you do it adequately. If you do it quickly and if you practice around on your patients every day. So, inspection. What to do? Look at the abdomen. It's recommended to stand at the foot end of a patient and look at the abdomen. Inspect the abdomen. What for? Distension or any obvious mass. Look for any abdominal distension that cannot signify any other causes, or there is any distension that you think is abnormal. You can inspect on an examination. Bruises. For example, bruises, trauma, colon signs, genitourinary signs. These are important to explain further in diseases respectively. Any bruises, any ecchymosis around. Scars for prior surgeries. For example, if a patient's with laparotomy before, as you can see, this is a vertical incision with laparotomies, or can present to you with constipation and other symptoms that is related to laparotomies or post-surgical complication. So with this simple inspection, you can realize this patient might be having some problem that is related to previous surgeries or any wound infection you can see on inspection. Cutaneous sign, portal hypertension, spiral nevi, SITs, as I mentioned before. Cutaneous sign, there is ecchymosis around, Turner sign, gray Turner sign, colon signs. These are present in respective diseases on inspection of abdomen. Colons and Turner sign, as I've explained before. So moving on to auscultation. Auscultation is a very, very important part of examination. What to listen with stethoscope, bowel sounds, peristaltic movements, very, very important thing. For example, if a patient comes to you with diffuse abdominal pain and you tend to auscultate his abdomen for peristaltic movements and there is no or absent bowel sounds, what to consider? Peritonitis. If a patient, for example, an elderly patient, present to you with constipation, long-standing constipation, and you tend to hear his or her abdomen, what do you tend to listen with auscultation? Absent bowel sounds, normal bowel sounds, or hyper-exaggerated bowel sounds. These all are indicators for bowel obstruction. Then, with auscultation, you can identify any vascular bruit, for example, renal artery bruit. Moving on to percussion. Percussion aids in determining the size and density of underlying matter. Percussion is very, very important. For example, if you see a gross distension of abdomen, especially in the patients with decompensated liver diseases, cirrhosis, and ascites. So this can make you identify fluid thrill or shifting dullness. These are two important steps in percussion that can help you. Is there any underlying fluid? It can be used in the estimation of liver, spleen, or bladder size, or differentiating different etiologies, abdominal etiologies. Next is palpation. Before going into guarding, there are multiple steps I want you to listen carefully that are important in palpation, and that can give you enough information of the diagnosis. With palpation, what to do first? Look for tenderness. Ask the patient, where is the pain? Because if the patient identifies the pain, the point of pain, the point of tenderness, that should be examined at the last of your palpation. First, the steps to palpation are: first, you need to identify external inguinal rings, femoral rings. Next, elicit with cough tenderness, cough reflex. Ask the patient to cough, and ask the patient to cough and identify the pain. Where is the pain with cough? Next, as I mentioned in the slide, is guarding. It's a very, very important point, a very, very important part of examination, especially abdominal examination. What do you mean by guarding? Guarding is muscular spasm, rectus abdominal muscular spasm. But at times, with the examination, patients are uncomfortable and they guard themselves. That's a normal reflex. But how to identify if the patient is voluntary guarding or is there any serious underlying diseases? So, how to identify, how to differentiate? You ask the patient to lay down comfortably. Make sure the legs are flexed. This relaxes the abdominal muscles. Ask the patient to breathe deeply and slowly. During palpation, while breathing, if there is no guarding, if there is no muscle spasm, this is involuntary muscular spasm. This is no guarding. But if there is still, the muscles are taut and stiff, this is a true guarding. True guarding is a manifestation of many, many critical diseases. Acute appendicitis, cholecystitis, perforated abdominal ulcers, stomach ulcers, diffuse peritonitis. These can present with guarding. Pancreatitis. These can present with guarding. So, palpation gives you enough information. Before moving on, how to palpate? Palpate with one finger examination. One finger palpation is highly recommended because this can help you identify or make you understand where exactly is the pain. This is superficial palpation. You identify with your fingertips where is the pain, because once you deal with your whole hand, you cannot identify the pain site. Look for costovertebral angle tenderness. Palpation of costovertebral angle tenderness can make you elicit this patient might be having pyelonephritis. Then go for depalpation. Depalpation, you can identify abdominal masses, any deep pain tenderness, With all this examination, what you can what you can make out of this examination of abdominal examination. With right hypochondrium tenderness, think of acute cholecystitis, distended gallbladder. With a simple palpation, you have a differential diagnosis. This patient might be having acute cholecystitis. Appendicitis, right iliac fossa pain. Diverticulitis, left iliac fossa pain. So with the simple palpation and the sight of the pain, this can help you in finding a diagnosis or making at least a differential diagnosis. Epigastric pain tend to have with pancreatitis, perforated stomach ulcer, abdominal ulcer perforation. Splenic rupture tend to have left upper quadrant pain. Costovertebral angle tenderness can elicit pyelonephritis. At times, guarding is unilateral because in a patient with especially a uretaric colic, a renal colic, the site where the stone is stuck inside, there the muscles are taut. So this is very important differentiating point. With peritonitis or diffuse peritonitis, you won't tend to have a unilateral guarding. This will be a bilateral guarding because peritoneal cavity is not in compartments. Rebound tenderness, a very, very important manifestation in acute appendicitis. How do you palpate? Ask the patient to lie comfortably. Make sure the patient's legs are flexed. Again, ask the patient to breathe deeply and slowly. Push the hand firmly and gently palpate the right iliac fossa. And ask the patient to feel the pain. And ask the patient if there is pain while pushing downward or hand down, or while moving hand up. At times with acute appendicitis, many of the times rebound tenderness is positive. How do you say rebound tenderness is positive? With hands down, there is pain, but when the hands are up, suddenly when you lift up your hands, there is excruciating pain. That's rebound tenderness, a highly clinical manifestation of acute appendicitis. Next is special signs. There are some special signs in abdominal examination that can help you make a diagnosis. For example, Murphy sign. It's most of the times is with acute cholecystitis. It's also called inspiratory arrest. How do you do that? A patient with right hypochondrial pain, during palpation, there is sudden inspiratory arrest while you palpate the abdomen. This is Murphy sign. Murphy sign is very, very important. It can be elicited on palpation and with ultrasound guided in a patient with acute cholecystitis. Sensitivity to acute cholecystitis. Rovsing signs. Rovsing sign is at times more characteristic in a patient with appendicitis. During the palpation of left iliac fossa, left lower quadrant, with palpation, while palpating the left lower quadrant, there is a pain in right lower quadrant or right iliac fossa. This is Rovsing sign and is important in acute appendicitis. Carnate sign. When you ask the patient to lift his head, there is pain in abdominal muscles. This is carnate signs. This is characteristic or is most likely a sign in abdominal wall tenderness. Sauce sign, explained in the next slide, is also a sign for any sauce muscle involvement or sauce muscle tenderness. How do you do that? We'll explain in the next slide. So, sauce sign. How do you do that? You ask the patient to flex against your hand, and there is pain in the sauce muscle. You can see here, sauce muscle tenderness. This is sauce sign. Can be in sauce abscess, sauce muscle tenderness, or at times can be in acute appendicitis. Next is obturator sign. You ask the patient to flex the thigh at right angle and with internal or external rotation, as you can see in this diagram, with external or internal rotation, there is pain in obturator muscle. So what is identify? Is to identify retropelvic, it can identify pelvic appendicitis, diverticulitis, and pelvic inflammatory diseases. So pelvic signs, which adnexal tenderness is important manifestation and during palpation. Uterine size or any discharge. With genital, go for a groin inspection. For example, in males with uncomplicated urinary tract infections, you can have a left epididymoarchitis or scrotal swelling. So this can help you identify any problem in the genital region. External genitalia scrotum evaluation. Rectal examination, for prostate, high riding prostate, or perirectal disease, stool impaction, especially in the patient with constipation, foreign body or GI bleeding. It can help. Rectal examination is very, very important in ischemic colitis as well, because this can give you an occult blood on rectal examination. So other abdominal signs, as I mentioned on the back of the abdomen, there is costovertebral angle tenderness, that characteristic of pyelonephritis. On the skin, pale, cool skin, moist skin, signs of dehydration, or increased capillary refill time, or signs of septic shock or septicemia. Jaundice and petechiae, especially jaundice and hepatitis, or obstructive jaundice, or patients with liver diseases can present with jaundice. This is yellowish discoloration of the skin and the eyes. Head to toe examination, pharyngitis can present with abdominal pain, as I mentioned before. Pneumonia can present with abdominal pain because of diaphragmatic irritations. MI is again a serious complication, is at times presented with abdominal pain. Moving on to differential diagnosis. I'll explain some of the diseases, with how they present with, what to do, and most importantly, what's the disposition, or what to do after the patient has been treated in ER. First, diverticulitis. Diverticulitis, as its name indicates, is inflammatory process. It presents most importantly in left lower quadrant pain. But at times it can present with also bowel habits, for example, constipation or diarrhea, and heme positive stools. So how to diagnose? CT scan, ultrasound, barium contrast, and enema. How do you treat this patient? Rule out the emergencies, rule out the septic shocks, rule out dehydration, rule out any sepsis. How do you manage? Fluids, crystalloids infusions, empiric antibiotics, and if mostly the patient with diverticulitis needs hospital admission. But if the patient is hemodynamically stable and can take orally, can be sent home with an immediate return in outpatient clinic. So next is appendicitis. It is a very, very common disease. What happens is, initially, with the patient with appendicitis, there is poorly localized pain around the paraumbilical region. But later on, the pain migrates to McBurney's point and right iliac fossa pain. So, if a patient comes to you with right iliac fossa pain, temperature, nausea, anorexia, and some episodes of vomiting, think of appendicitis. How do you differentiate appendicitis? What's the severity of appendicitis? Should be considered. There is, at times, especially in females, at times it's difficult to make a diagnosis appendicitis versus any other gynecological or pelvic diseases. For example, ovarian cyst can present with right iliac fossa pain. But appendicitis is very, very common, especially in children. How do you identify? What do you get in palpation? Again, as I mentioned before, rebound tenderness is very, very important sign in appendicitis. Other special signs, obturator sign or SAW sign, can help you differentiate or identify appendicitis. How do you diagnose? Ultrasound is important. Ultrasound is sensitive at times and is really considered in females with reproductive ages. But CT scan is gold standard. CT scan with contrast, IV and oral contrast is gold standard. It is sensitive and specific as well. What to do with this patient with acute appendicitis? Vitals, fluids, give this patient IV fluids, empirical antibiotics, and the next thing, prepare for surgery. Because if not treated, it can be complicated to appendix abscess formation around it, or ruptured appendix that has fatal outcomes. So CT scan and ultrasound can help diagnose appendicitis. Bowel obstruction. Bowel obstruction, as I mentioned in the section of palpation and auscultation, bowel obstruction is very, very common, especially in elderly males and females. What is the most common cause? Adhesions. Post-surgical adhesions can cause bowel obstruction. So how do a patient present with? Poorly localized pain, diffuse abdominal pain, absent or high-pitched bowel sounds, history of no passage of flatus or stool in the past few days. This can help you identify or make a diagnosis as a bowel obstruction. How to treat? Relieve the bowel obstruction. How to diagnose? Plain films and CT scan. But at times in elderly, it is required to have a CT scan, because this help the elderly patients to be not to be misdiagnosed or not to be missed with constipation. So next is biliary colic and cholecystitis. The presentation with biliary colic and cholecystitis are somewhat the same. In biliary colic, what happens is there is stones in cystic duct, which causes the pain. This is intermittent, relapsing kind of pain, and it is at times more after ingestion of the meal, especially the fatty meals. So what to do with the patient with biliary colic? First, rule out surgical causes. If the patient is not with acute cholecystitis, if the patient is not with pancreatitis or acute cholangitis, this patient can be sent home, but pain should be considered first. The patient should be managed with pain management. With acute cholecystitis, there is similar kind of pain, similar kind of presentation the patient might present, but the pain is persistent. The pain is constant. The pain is associated with vomiting. The Murphy sign is positive. The ultrasound, while doing the ultrasound, the Murphy sign on ultrasound is positive. Ultrasound is gold standard. It's not gold standard, but it's highly specific and sensitive. It can give you and can diagnose acute cholecystitis within minutes without going for any further radiations. Though the diagnostic scan for acute cholecystitis is HIDA scan, but most of the times ultrasound gives enough information. So, ultrasound preferred emergency department study, radionuclide scan, HIDA scan, liver function test, amylase and lipase. Because why amylase and lipase? Because pancreatitis can present with right hypochondrial pain. So what to do with the patient with acute cholecystitis? This patient needs admission. IV fluids, pain management, analgesia, empirical antibiotics, and surgical consult. It's very, very important. So next is ectopic pregnancy. Ectopic pregnancy is very, very important in females with childbearing age. A female present to you with especially left lower quadrant pain and is of childbearing age, rule out ectopic pregnancy first. The ectopic pregnancy can present with left lower quadrant pain, vaginal spotting, or amenorrhea. So, how to diagnose? What are the risk factors involving ectopic pregnancies? A patient with a history of previous ectopic pregnancies, smoking, intrauterine devices, contraceptives. These can help you make you realize this patient has a risk factor and needs to be evaluated for ectopic pregnancy. How do you do that? Ultrasound and quantitative beta HCG. Very, very important. Ultrasound is very, very sensitive. At times, ectopic pregnancies initially, when there is no rupture, the patient can present with poorly localized or intermittent pain. But when there is ectopic pregnancy rupture, this patient can present to you with hypotension, tachycardia, and deperfusions. So, ultrasound and quantitative beta HCG, urine for serum pregnancy test to rule out any pregnancy, RH type, and hematocrit. Hematocrit is a very important sign of dehydration. With increased hematocrit, signs of dehydration. Decreased hematocrit, signs of overhydration. So, what to do with the patient of ectopic pregnancy? This patient needs admission. This patient might need surgery. So, treat hypertension, treat shock, give fluids, IV antibiotics, analgesia, gynecological consult, and may she require an emergency surgery. So intussusception is, as you can see in this diagram, is telescoping of the intestine. So how do you make the diagnosis? Abdominal plain films can help you make the diagnosis. Barium or air contrast enema can help you make the diagnosis. Ultrasound and abdominal CT. It is a very, very important to rule out intussusception. So other differential diagnosis, ovarian torsion, a very, very emergency condition. What happens is there is torsion of the ovaries. With the torsion, what happens? There is increased chances of ovaries becoming dead. So what to do? Transvaginal ultrasound with color Doppler is specific and sensitive most of the times. What to do first? Treat shock, analgesia, straight to operation room. Needs emergency surgery. Need to save the ovary. Pancreatitis. It's a common presentation. A patient presents to you with upper epigastric pain, severe intensity, radiating to back, associated with nausea and vomiting. Think of pancreatitis. And there is typical guarding on palpation. Amylase and lipase. It's a routine. The patient who is suspected with pancreatitis, amylase and lipase are sent. But amylase is raised in some other conditions as well. But lipase is more specific for pancreatitis. So lipase alone can help you make the diagnosis of pancreatitis. But if the diagnosis is uncertain, go for abdominal CT. So what to do? Nil per oral. No, not to be given anything by mouth. Should be given nasogastric tube, IV analgesics, IV antibiotics, admission, and further management. This patient needs admission. So next is perforated peptic ulcer. A patient presents to you with sudden onset of severe epigastric pain, upper epigastric pain, with a history of gastric ulcer or NSAIDs-induced gastric ulcer. Think of peptic ulcer diseases, perforated peptic ulcer diseases. This is an emergency. So what to do? Plain films and abdominal CT can help you diagnose peptic ulcer. But what to do first? You got the diagnosis. Treat hypertension, treat sepsis, treat the patient's shock, give analgesia, and straight to OR. This patient needs emergency surgery. Testicular torsion. Males present to you with sudden onset of testicular pain, constant in nature, not relieving with anything. And when you on examination, you find coldness, think of testicular torsion. Make the diagnosis with ultrasound, straight go to OR. This patient needs surgery, emergency surgery, need to save the testes. So next is mesenteric ischemia. It is also very, very important diseases and emergency disease. How do a patient present with mesenteric ischemia? This sudden onset of abdominal pain, poorly localized, out of proportion pain, cannot be relieved with narcotics. There is no relief with narcotics. The pain is radiating to back. Think of mesenteric ischemia. What is the underlying cause? Thromboembolism or thrombosis. What to do? Straight away, CT angio. Abdominal plain films, enhanced MRA, angiography, serum lactate levels can help you make the diagnosis. But you need to be quick, on your toes. With CT angiogram and with all these investigations, this patient should be admitted and to be proceeded for surgery. But before that, this patient needs to be treated for hemodynamic instability, like shock, IV fluids, and, if required, blood transfusion. So, ruptured abdominal aortic aneurysm. This is also a very, very high yield and very, very important disease. This can kill the patient, but you need to identify, you need to treat it as soon as possible. So if there is leakage of abdominal aorta, abdominal aortic aneurysm dissection can present with abdominal pain or pulsatile mass, pain radiating to back. What to do? Plain films in CT, ultrasound, emergency ultrasound, straight to OR. This patient needs surgery. On the other hand, renal colic, ureteric renal colic, the patient presents to you with unilateral pain associated with nausea and vomiting. The pain is radiating to the groins, can at times present with burning micturition. Ultrasound and KUB can be diagnostic at times, but non-contrast CT is diagnostic. It can help you measure and find the location of the stone, a renal colic stone. So how do you treat? Pain relief, but if there is significant hydronephrosis with it and leading to renal damage, needs urology consultation and might need surgery. But if it's not, can be sent home with increased water intake and follow-up in urology outpatient clinic. Urine analysis may show hematuria, but it's non-significant. Volvulus. How do you diagnose volvulus? Abdominal plain films, barium enema, sigmoidoscopy, and might need surgery. So moving on to laboratory studies. So what to do first? CBC, complete blood count. What it shows, hematocrit, signs of dehydration, overhydration. If hematocrit is less, there is signs of overhydration. If the hematocrit is increased, signs of dehydration. Blood hemoglobin levels, platelet counts, WBC count. Though WBC count is non-specific, but yes, it is important. Urine analysis. Urine analysis shows leukocyte count, specific gravity, hematuria or no hematuria, proteins, glucose, especially in patients with diabetic ketoacidosis. Pregnancy test, very, very important. For example, in the patients with ectopic pregnancy, should be ruled out with pregnancy test. Amylase and lipase, pancreatitis, lipase more specific as compared to amylase because amylase is increased in many of the conditions, but lipase is more specific. Liver function test, any liver diseases going on, Hep C related decompensated liver diseases, jaundice, these can be identified liver function test. Radiological studies, ECG, electrocardiogram, again, it's very, very important. Patient present with abdominal pain, multiple risk factors, history of cardiac diseases, first EKG. Won't take much of your time, but can help you identify and give you a lot of information of underlying life-threatening diseases, if it's cardiac in origin. Plain films, chest x-ray or abdominal x-rays, abdominal erect abdomen can help you identify for any bowel obstruction. Air on the diaphragm can be appreciated well in anterior posterior view of abdominal x-rays, help you identify perforation. Ultrasound, most commonly for acute cholecystitis, ectopic pregnancies, appendicitis in females who of reproductive ages, pancreatitis. These ultrasound and acute cholangitis. These are ultrasound is very diagnostic at times and very specific and sensitive. So abdominal CT scans with IV contrast, with oral contrast, help you identify many diseases, site of constipation if there is, CT angiogram for aortic aneurysm leakage, for renal colic, for pancreatitis. These are very, very important. Gas in the diaphragm or perforated ulcers can be helpful in diagnosis on CT scan. So, general treatment principles. How should patient be managed? So, yes, again, treat the life-threatening causes first. Vitals, hypertension, fluids, tachycardia, compensatory, because of hypertension, needs fluids. Prevent the patients from going into hypovolemic shock. Pain relief and antibiotics, empirical antibiotics of many diseases I've told you before, diverticulitis, appendicitis, acute cholecystitis, needs empirical antibiotics. Pain relief is the first. NG tube insertion. NG tube insertion is in various diseases. For example, in a patient with constipation, absolute constipation, what happens is when you put the nasogastric tube inside, it helps to relieve or decompress the gastric contents. It helps in patients with pancreatitis. So it's an important thing. So coming to some special patients. Elderly patients, they are prone to many abdominal diseases. For example, constipations, tumors, cancers. And at times, they are misdiagnosed or underdiagnosed. So in elderly patients, look for surgical causes. There's a greater risk in a patient with elderly patient of surgical causes. CT has more of an effect of a diagnostic value in a patient with elderly as compared to patients with young age. 1/3 require surgery. But the problem with elderly patients is they lack the classic findings of the diseases of many other reasons. Elderly patients tend to have many underlying chronic diseases due to degenerative changes as the age progresses or senile changes. So they tend to mask the classical findings in elderly patients that are diagnostic otherwise. So in elderly patients, CT scan overdiagnosis is very, very preferred as compared to underdiagnosis. Patients with elderly males, especially more than 50 or 65, CT scan is diagnostic. Need to go for high radiation investigations. Pediatrics. In pediatric patients, the pancreatitis is not that common. Constipation is common in neonates. But the most common presentation in pediatrics is appendicitis. abdominal pain, abdominal pain following viral infections is common. Appendicitis in pediatric population is at times when they present can be with late complications of appendicitis. For example, perforated appendicitis. So obtaining histories is at times difficult, can present with later symptoms of diseases because they cannot communicate, especially with neonates and young children, infants. Most commonly present with gastroenteritis and appendicitis, non-specific abdominal pain. Rarely in children there is a chances of Hirschsprung diseases and valvulus. So these needs to be treated as soon as possible. So moving on to pregnant females. At 12 weeks of gestation, there is increased abdominal distension because of uterine enlargement. So as a physician, it is hard for you to appreciate or to even inspect the underlying diseases or underlying cause of abdominal pain. So at times, abdominal pain can present with gynecological causes, for example, fibroids, appendicitis, but the position of appendix in pregnant females is different. So this needs to be evaluated. Pregnancy-specific condition, for example, inflammatory diseases, fibroids, any ectopic pregnancy. So pregnancy in females, pregnant females should be investigated considering two lives, one of the mother and one of the fetus. So the fetus and the mother should both be protected, for example, from radiations and from the painkillers or from pain management, which are toxic for the mother and the fetus. Should be done with minimal invasive surgeries, minimal invasive lab investigations that can help you make the diagnosis. So these all maneuvers can help to make the life of mother and the fetus healthy and easy without any further complications. Immunocompromised. Enterocolitis with profuse diarrhea. Patients with immunocompromised are prone to have cytomegalovirus. So cytomegalovirus can lead into enterocolitis with profuse diarrhea and eventually dehydration, further worsening their symptoms. Large bowel perforation with cytomegalic virus, again. Bowel obstruction. Immunocompromised people tend to have decreased peristalsis, which leads to increased bowel obstruction and impacted stool, and eventually leading into abdominal pain. Biliary tract diseases with different viruses. Cryptosporidium can attack in a patient with immunocompromised. Drug-induced pancreatitis. Yes, as I mentioned, chemotherapy. Chemotherapy can induce pancreatitis. Chemotherapy, immunocompromised tend to have neutropenic sepsis. Neutropenic sepsis can present with abdominal pain and tend to have more abdominal diseases as with a healthy individual which are not immunocompromised and are immunocompetent. So disposition, as I mentioned before while discussing some diseases, what should the patient be? What mood should the patient be? Where should the patient be after treating in emergency department? Who needs surgical consultation? Appendicitis, acute cholecystitis, perforated duodenal ulcers, perforated bowel ulcers, perforated peptic ulcers. Pancreatitis needs surgical consultation. Appendix, as I mentioned before, ectopic pregnancy, mesenteric ischemia, abdominal aortic aneurysm, they all need surgical consultation. Serial evaluation. For example, the patient comes to you, the pain is gone now, the patient is hemodynamically stable, but there is increased risk of patient getting worse again, should be admitted and should be evaluated again and again. And it is said with serial evaluation, you tend to have a greater diagnosis and an effective treatment in a patient who are admitted and who are undergoing a serial evaluation. Discharge. Who to discharge? As I mentioned in the topic of biliary colic, if there is no acute cholecystitis, pancreatitis, acute salpingitis, or acute cholangitis, the patient can't be sent home. But keeping in mind, the patient should be informed the risk factors, the probable outcome or the probable progression of the disease, and probable red flag signs, and ask the patient to return to emergency department if they recognize any red flag signs. So, pearls, pitfalls, and myths. Do not restrict diagnosis by pain location. If you think there is an epigastric pain, just don't think this is due to gastric diseases. At times, with diffuse pain, you tend to elicit pain everywhere around the abdomen. On the other hand, with Rhine-Hypochondrial pain or acute cholecystitis pain, this tend to be radiating to scapula. With acute myocardial infarction pain can be an epigastrium. Do not restrict your diagnosis on the site of pain. Next, consider appendicitis with patients with right iliac fossa pain, adnexal pain, or history of gastroenteritis. Think of appendicitis in these patients. WBC count is of little value, right? If the patient is with gastroenteritis, abdominal pain, and WBC count is raised, nothing to do with it. Fever is not a differentiating point if the patient needs a medical or surgical cause. Fever with life-threatening injuries, need surgery, proceed for surgery. Pain medication and ECG. The patient should be given pain management. It's not important. It's not like if you don't give any pain medication, you can miss the diagnosis. No. Treat the pain first, let the patient be comfortable, then go for examination. You will get to the diagnosis, but not like if you give the patient the pain, there will be no pain on examination. You will get to see the diagnosis, you will tend to have a diagnosis, but first make the patient comfortable. ECG is important. Again, repeating again, high risk factors, diabetic hypertensive, previous ischemic heart disease, presenting with abdominal pain, EKG. Won't take much of your time, but give you much information. Abdominal ultrasound or CT scan. Patients with appendicitis, patients with physical examination, history and physical examination suggestive of appendicitis, no need for CT scan. Proceed for surgery. Elderly patient, increased risk of surgical diseases, so should be evaluated adequately. CT scan is a preferred choice. Go for high radiation scans in elderly patients. Ectopic pregnancies with left iliac fossa pain, with amenorrhea or vaginal spotting. Think of ectopic pregnancies until and unless your pregnancy test is negative. If it's positive, think of ectopic pregnancy, straight to OR. So, in this lecture, it was a continuation of the part 1 of abdominal pain. In this lecture, it was more details about specific diseases, some emergency diseases, what to do in these patients, how to proceed, how to manage in this patient, and what should be the disposition of this patient. Whom should be sent home, whom should be sent with on serial evaluation, and who should be sent straight to operation theater. That's all in abdominal pain management. Thank you for watching sqadia.com.